can we do any testing in the hospital, even if it's not recommended, if there's a high suspicion? What testing would still be valid, and what are the misinterpretations if they're on a blood thinner? And then 3 months when they're off of it, what does the testing look like?
Yeah, the ones at least at our center are antithrombin protein C and protein S. You can check for Leiden and Prothrombin, and there actually is a functional clotting assay for activated protein C resistance, which can be used for screening for Leiden. It's actually a very good screening test, but it could be affected by anticoagulation. If you do the genetic tests, Leiden or Prothrombin, those can be done anytime because they're genetic. So those are no problem to do, assuming that they haven't been, given blood transfusions or things that might have leukocytes in them or contaminating DNA. But those can be done anytime. And again, there you pick up heterozygosity and rarely homozygosity. If Leiden's present 6% of the population, homozygosity is present in 0.06 times 0.06. And then similarly, the prothrombin mutation, homozygosity 1 in every few thousand. So they're not off the table, and those carry even a higher relative risk of a first event and might affect you. So this could be done anytime. Antithrombin can be driven down by heparin. Many, many years ago, it was shown that heparin therapy can lead to acquired antithrombin deficiency in the hospital, probably by accelerating antithrombin clearance. Antithrombin, too, can sometimes be depleted in the setting of large clot burdens. So antithrombin is problematic in a way that if you get a low level, even before you start any heparin, it could be affected by very large clot burden, perhaps. Protein C, not so much, but they're all made by the liver. So if somebody presents with a massive PE and shock liver, not a great time to check for protein C. And protein S is the most complicated of the group to test for. There's a bound form or free form. They're functional antigen assays. So I think you could test for it. And if you get completely normal answers, you're done pretty much. The thing with the DOACs, though, so I mentioned heparin being a problem. In the Warfarin era, protein C and protein S are both vitamin K dependent proteins. So if you used Warfarin, their levels go very low, as do 2, 7, 9, and 10. So you really lose your ability to interpret what is a heterozygous deficiency. So Warfarin really totally confounded your ability to make the diagnosis, both inpatient or outpatient, too. So in the DOAC area, there's some different kinds of problems based on the nature of the assays we use. It turns out that the largely used protein C activity assays aren't affected by DOACs. There are 2 antigen assays for antithrombin antigen and free protein S antigen, which are not affected by DOACs either. The big issue becomes antithrombin activity, which is a factor 10A based assay using a synthetic chromogenic substrate. So it's not in a clotting environment, but it throws in 10A in the assay to bind to antithrombin heparin in vitro. So if you add in a DOAC, which is a 10A inhibitor, it essentially can give you a fake antithrombin signal, give you a falsely normal AT activity. So I tend not to do AT activity levels on DOACs. I'll do AT antigen. So there are real nuances about the timing of testing. And I must say, most of us recommend against thrombophilia testing in the acute situation, unless clearly decisions need to be made on the way out the door. Let's say somebody who presents with a prolonged APTT where you're suspicious they have a lupus inhibitor, and maybe they might be a patient, even though you haven't gotten the confirmation at 90 days, whereby you may not just send them out on a DOAC. Maybe you'll say, gosh, I'm really worried that maybe this patient has APLS, and have your intent up if you send the tests. The lupus anticoagulant be tested right away if it's not done in the absence of anticoagulation, and see if they have a lupus inhibitor, and maybe think about treating like an antiphospholipid patient with bridging of a heparin to warfarin, admittedly without having confirmed at 90 days, but just because you have a high suspicion, particularly an arterial event. But again, I think if there's nothing that says strongly this is APLS, sometimes you're better off not doing the testing and leave it to the outpatient. But arena to sort out whether or not testing needs to be done or not.